So, my name is MichaelHowell. I'm at the University of Chicago, and as you look at the title, I'm sure you're sitting there wondering, who let this guy in? It seems kind of negative, right? And I'll try and walk you through some of the things that I am worried about deploying clinical analytics across the country. I'm going to start by saying I'm not an informaticist. I am an ICU doc who last saw patients 7 days ago. I'm a chief quality officer, so I'm responsible for implementing all those programs that Dr. Goodrich talked about for a $1.4 billion enterprise. I have direct oversight of the operational analytics group. I ran a research analytics shop for a while, and then my research teams use what I would call tolerably large data sets of 10 to the 8th pieces of data. I'm also, terrifyingly to me, now into my third decade of technology-enabled analytics, which is shocking. I am spectacularly hopeful in spite of the talk's title, but I have learned a few things that make me worry, and I'm going to share those with you. I started working at Rockwell when they were the prime contractor for the space shuttle, actually across the street from a MITRE installation, back when token ring networks were a thing, and we were all opening NCSA Mosaic 1.0 for the first time. I worked at Dr. Celli's shop, who you'll hear in a little while, at the Beth Israel Deaconess at Harvard, running a research shop in how to get information out of the computer to use for research, the best acronym I'll ever come up with in my entire career. And we did a lot of work. These are a few of the things we did. We learned that those little acid suppressive pills that you all take, or that I take, cause some bad things. We learned we could build complete electronic cohorts out of the electronic medical record and do science out of that. We learned that we can predict some things that you might not think you can predict, who will be dissatisfied with care before they have their care experience. And working with a group from MIT, we learned that the math is hard. We learned that the math is hard to do this. At the University of Chicago, where I've been for 2 years, we are deeply invested in becoming a smarter hospital. I'll give you 2 examples of that. We've done a bunch of work in cardiac arrest, in preventing and treating cardiac arrest dating back to 2005. We have a group who has been using progressively more sophisticated data sets to predict who will have a cardiac arrest before they have it. For those of you who aren't clinicians, the difference between a heart attack and a cardiac arrest: a heart attack, 5% of people die. Cardiac arrest is the recognition that you are dead. And so it's a somewhat more serious condition. This last one was 270,000 patients, 5 hospitals, a really complicated 27-dimensional model, splines, the whole 9 yards, to come out with something that gives you 8 to 12 hours of warning before someone dies in your hospital. But what do they have? They have a paper, right? They're not affecting any human being in the real world. And what we are here today to talk about is action, right? I try to not manage my $1.4 billion enterprise by fortune cookies, but it's a good fortune cookie. And so we are invested in how to do this, right? And so, again, I'm not an informaticist. I barely know what an enterprise services bus is, but we bought one, and it turns out it's the same one that is used by a bunch of very data-intense organizations, right? That we all trust that they actually know what they're doing with their data. And we took the world's best cardiac arrest prediction algorithm and we built it into the enterprise services bus that FedEx and others use. And we turned it live last month, 2 months ago now. So we have ICU nurses wandering around with iPads that every time a vital sign is taken or every time a lab is resulted, the risk, 27-dimensional risk of this patient having a cardiac arrest is recalculated, shows up on their iPad, and if something acute happens, bad, good, like happened here, it pages them, right, without talking to anyone. So we turned it live one cold February morning at 7 in the morning. eCard is the name of the algorithm. And at 8:20, the pager went off. The team went to the bedside and found a 30-something-year-old woman who had a pneumothorax, a collapsed lung, figured out what was going on, put the chest tube back to suction. Everything was fine, right? Would our usual systems have caught her? Probably. But now we don't have to find out. So cardiac arrest, really fancy, new technology, but we're also working on the basics with analytics, right? Cleaning hands. We know that the traditional way we look for who cleans their hands overestimates by 3-fold. You think you're getting 90%, you're actually getting 30. We invested in an electronic platform that monitors who goes in, who goes out, who cleans their hands, all those things. What is surprising about this is not that we're improving hand hygiene, which we are. What's surprising is the scale of data. 83,000 observations per day, each of which is temporally and spatially distinct. What does that mean? It means you have genomic scale data from routine operations. You can take these data and actually, hospital room, hour, million cells of data per month, you zoom in, it actually looks like a gene plot, right? And something happened here where it's red. Well, it turns out that's the unit that we're working on. What's even cooler than that, and we're just getting into this, is now we can apply genomic analytic techniques to routine operational data. This is a hierarchical clustering model that I used a genomic analysis program, and it treated it like a gene map. Really interesting stuff. So, Howell, that doesn't sound all that negative, right? So why are you worried? There are three things that I worry about, right? Here they are. The first is it's obviously the right thing to do these next generation analytics, right? Well, what is critical care learned? We have learned the peril of doing the obviously right thing. I'll give you 3 examples of that. We have learned that when we do the thing that is obviously right, we leave corpses behind. Here's one example. We obviously need more data to understand how to treat shock, right? Shock is really bad. So Jeremy Swan and Gantz invented a gizmo to do that, put it in, measure some pressures. By the 1980s, 4 out of 10 ICU patients had this procedure done to them. Millions of patients, billions of dollars, even in 1980s dollars. Over the next 2 decades, studies unfolded showing no benefit on average and probably increased mortality for some patient populations. It took us 43 years to put this thing to bed because it was obviously the right thing to do. It's obvious you can't let people starve, right? So if you can't feed their gut or they can't eat, you need to give them IV nutrition because you can't let them starve. It's obviously right. The group studied this, published it in the New England Journal, and found that letting people starve for a week resulted in fewer complications, fewer infections, and getting out of the ICU faster. But that's not obviously the right thing to do, right? The one that causes me personally the most pain, don't let the blood sugar get out of control. Out of control diabetes is lethal. Control the blood sugar very tightly. We implemented this across the country. You heard the story about the SCIP-4, the measure related to surgery. When this was studied in ICU patients in a very large study, the NICE sugar study, here's what we found. For every 38 people whose blood sugar we controlled more tightly, we killed 1 extra person. We implemented that in millions of patients across the country because it was obviously the right thing to do. So next-gen analytics are obviously the right thing to do, right? So that's number 1. Number 2, thing I've learned number 2 is that human factors are like gravity. You can complain about gravity all you want, but you better understand it before you launch your rocket, right? We've all seen these hilarious bad human factors things in the real world. You know, somebody had to get out a Sharpie to fix this one. Somebody had someone walk in on them in an inappropriate moment in this bathroom lock. I had my favorite, which was on the door of a very famous clinical informatics group, was this one. I would go and have lunch there and just watch people bang into it all day long. That would never happen to us as we deploy clinical analytics, right? I'm going to give you 2 examples of how it will, because we all are wired in the same way. Can I ask you to pick a card? Okay, got it in your head? Don't tell me what it is. Got it? Okay, everybody can play along, but I'm going to make you forget it. Right? Got the card? It's really easy to forget. What's the capital of Montana? Helena, right? Only 1 out of 3 people get that right. Still got your card? So I'm actually going to see how predictable you are. And what I did was I removed your card. Did I get it right? I got it right. Who'd that work for? Right. So now we're going to simulate something harder, a task like diagnosis. And I'm going to just show you a video of a magic trick and ask you to figure it out.
Hi, I'm Magic Singh, and today we're in Portobello Road, and I'm going to show you guys a classic in magic using matches. And today to help me out is Mark. Mark, tell you what, place your hand up for me nice and flat. Now, I promise this won't hurt, all right? So here's the idea. Let's just light this up. And if you close onto that nice and tight, here we go. Watch this.
Keep watching.
Don't know if you felt that or not. I'll tell you what, have a look inside. Open it up. See how the match is actually returned into the book, and it's still burnt. Okay, you're not impressed. All right, it was my first trick ever. But here's the idea. Just place that back in your hand, close it tight, and turn it face down again if you can. Now we're going to use one more thing, and we're going to use a magician's best friend, playing cards. Now the idea is really simple. You're going to choose one. So take any one you like. Perfect. Have a look for yourself, and do me a favor, show the camera as well if you can. Brilliant. And you know what? Place it back face up on the deck. Now, it doesn't matter if I see what the card is, because we're going to do something completely different. Just watch this. Here we go. I'll do it slowly. Watch the king. I don't know if you felt that or not. No. Tell you what, have a look inside. Open it up.
Oh.
Check it out.
It's the King of Diamonds. It's my card.
Brilliant. Thank you very much.
I have no idea how that trick is done. What'd you notice in the environment? So let me show you a couple of things you may not have seen. See, he's got the red thing here. Good. Green, right there. Did you notice anything else? All right. Here we go. Watch his $150 shirt. It's going to change into a $9 Hanes undershirt. Right? $9 Hanes undershirt. And here's the most dramatic one. Look at this dude right here. Fix him in your mind. My friends, that is a completely different human being. Who saw it? Right. So a room of people who will decide the future of clinical analytics in the country, I just changed out a human being in front of you, and the vast majority of you didn't notice. Look, a shiny new algorithm. Oh, we didn't notice what happened to the patient in front of us. Right? So it's not you, it's human neuroanatomy. And I know the fact that you have Dr. Harasovich here shows that you care about this. They're one of the few groups that's done really interesting work in this. And the last thing that I've learned is that the road to purgatory is paved with well-intended incentives. Remember the hand hygiene work we talked about? Let me show you some of that fancy genomic things. As we worked really hard to get it up, we made it very important for people to do hand hygiene with real-time feedback. And now I'm going to take that gene map, I'm going to dial the p-value way down so that to get red, you have to be 99th percentile of using hand hygiene. You have to be 99.99th to get yellow. We're going to zoom in down here. Wow. Time going this way. One dispenser. Huh. Really strange, right? So we pull the individual data for that dispenser, how many uses per hour, bang. We pull the security video. We find a healthcare provider who'd been told it's really important to get hand hygiene up and stood there and did hand hygiene. You think it's just us? Anybody here from Cleveland? Anybody know the Cleveland Health Quality Choice Program? You're going to read one paper in your life. It should be David Baker's paper about this. So here's what they did. 1989, multi-stakeholder group wanted health reform. They gave public reports that were actually very good risk adjustments for mortality and length of stay, and mortality fell dramatically. Here's what happened with pneumonia. And this is a giant decrease in the risk of death from pneumonia. How could this possibly be a problem? Well, here's what they found. It was actually death shifting, that they just moved all the deaths to immediately after discharge, and that 30-day mortality didn't change at all. So it's a normal human response to incentives and measurement that we behave in ways like this. It's not just at the University of Chicago. So that's number 3 that I've learned. What do I want you to take away from all this? Well, I want you to take away The peril of doing the obviously right thing. Don't assume that this will work. We have to fund the evaluation. We have to be open to the idea of unexpected harm. Because I got to be honest, we're not that smart, right? We have to measure it. We've learned again and again in my specialty, doing the obviously right thing leaves corpses behind unless we measure what's going on. Number two is that human factors are like gravity. You better understand them before you launch your rocket. We are not one clever algorithm away from fixing all of U.S. healthcare. We need to co-invest in understanding the socio-technical interface, how people relate to machines. Really important and really underfunded. Otherwise, we will be creating knowledge, but we will not be creating action. The difference between the paper and the iPad app with an ICU nurse going to help a patient. And the last thing about incentives, you're going to have to hire people who are smarter than I am. I don't know how to fix that, right? I know that my hospital, we responded to skip 4 by keeping people in the ICU an extra day because we could control their blood sugar better there, right? Aberrant response to incentives. Really important to get policy right in this. Thank you.